My name's Sophia, if you don't know me. I'm going to be doing the PTCM lecture. Big shout out and thank you to Tien. He helped me so much with this. I titled it The Journey of a Threenager. Apparently, a 3-year-old's nickname is a Threenager. This is a real case at County last month. It was actually a 3-year-old female, but I wanted to use pictures of my nephew, so I changed it to a male. But he presented to the ED like early December, December 1st on a Tuesday, complaining of abdominal pain, vomiting, and diarrhea. In terms of just like the further history, the father basically said that the patient was complaining of abdominal burning pain and had 10 episodes of vomiting since Sunday, and then 1 episode of diarrhea on Sunday as well. The reason why the father brought the patient 2 days later, which was the day that they came to the ER, was for a few reasons. 1, the patient was with the mother and he just took over care that night before. 2, the patient just kept over and over again saying, like, I'm having some burning stomach pain. And then when he went to go evaluate her during that night, he felt that she was warm. So basically brought her in. Let me just make sure we're okay here. Give me 1 second. In terms of the vitals, overall the vitals were basically a little bit hypertensive, tachycardic. The patient was febrile as well. The team that was taking care of the patient kind of mentioned that the child was extremely anxious to be there as well. So that could just also the high blood pressure could have incorporated that. But there was no signs of respiratory distress on the vitals or physical exam. In terms of the exam, well appearing, aside from just being stranger danger anxious, okay, tachycardic, clear lungs bilaterally, and given they came for an abdominal pain, the abdominal exam, there was soft, non-tender, no rebound or guarding. So can people just kind of, first of all, I just want to get kind of a consensus. How many people have seen this patient in the PDR? Abdominal pain, vomiting, diarrhea, fever, right? That's like every kid we see. I promise I'm not talking about gastro. But for our preliminary problem list, can some people just shout out or put in the chat what our problem list is going to be about? Being too cute. That's true. Thanks, Trevor. Fever, good. Abdominal pain. What else? Diarrhea. Vomiting, hypertensive, tachycardic. Perfect. Paul's jumping the gun here. In terms of our differential, what would you guys think? Paul put an intussusception on a differential. What else? 3-year-old, abdominal pain, vomiting, diarrhea, fever. Gastroenteritis.
I said the same thing.
Okay, yeah. What else? DKA, Andrea said, volvulus. Okay, I think those are pretty good. I threw in UTI, API, and then just foreign body injection. So the ED's initial assessment was likely gastro from what I talked to the team about. So they basically gave liquid Tylenol for analgesia and then wanted a PO trial the kid. Totally reasonable, right? On reassessment, however, the patient did tolerate PO even though given they had 10 episodes of vomiting, but kept specifically complaining about like this burning pain in the belly, and it was not improving with the analgesia. Even though the belly was soft, non-tender, yeah, Andrea said possibly GERD, question mark. The ED team went back to the room to just kind of talk to the father a little bit more, like, why is she complaining of burning pain so much? Like, it's a little bit weird, what's going on? And so talking to the father, he said, well, I haven't taken care of her for the last 2 days. It was my ex-wife. But then he was like, oh yeah, she told me that the patient had swallowed some coins 2 days ago. And then since then, been having some burning pain and complaining of the vomiting. So what would probably be the next step you guys do? X-ray, right? Okay. So an X-ray was done. There was a chest and abdomen. Anyone want to say what they see?
Can you turn on the lights?
Yeah, let's try. Yeah, let me zoom in just so we have a better view. So what do you guys think? Button battery? Trouble. Yep. All right, yep. So button battery ingestion. So, and we'll kind of go over how you can kind of discern that from a coin later. This just kind of is a picture that kind of helps you here too. The radiology read was a 2 centimeter flat battery within the distal esophagus just above the GE junction. All right, so now what would you guys do? GI? Okay, cool. Surgery, okay. So yeah, they consulted Pete's GI for basically requesting that this patient needed endoscopic removal. GI came right away and also agreed that the patient needed emergent endoscopy. And the patient was transferred to downstate so they could basically get the EGD done. After the EGD, the GI notes, like their recs basically said, based on EGD, recommend admission to PICU, keep NPO, start on PPI and antibiotics. Thanks to Smriti, who was at downstate last month, I got the images. And these are just the images from the EGD report itself. Here's just the coin that after they removed it, but you can see like the necrotic tissue basically all around the esophagus. The EGD report read that they took a 2-centimeter lithium button out that was lodged in the distal esophagus, and the patient had circumferential eschar covering the whole mucosa 3 to 5 centimeters above the LE sphincter. So patient went to PICU. So if we kind of take the time course, right? So the patient came 2 days with like after the ingestion, came to our ER on the December 1st, had the EGD done, which was like around midnight actually, and then got admitted to the PICU. 3 days later, had an esophagram done, which was unremarkable. 2 days after that, finally achieved their PO tolerance on their PO trial diet, which we'll talk about in a second, and then was discharged the next day. To kind of talk about the inpatient stay a little bit closer, the esophagram was just basically to make sure there wasn't extraluminal contrast, make sure there was any strictures, which was negative. And actually the diet that they were tolerating was a Pediasure diet. And per nutrition's note, the goal for that 3-year-old to meet like their nutritional capabilities was 5 to 6 bottles. So they like were able to meet their nutritional capacity on the 5 days out. The discharge recommendations per GI was they have to be on a liquid diet with Pediasure, stage 1 baby food or puree, which means no chunks or solid foods. And that was for 28 days that they had to keep that diet. PO liquid PPI, and a repeat esophagram and EGD in 3-4 weeks. Unfortunately, I checked the chart yesterday. They did see Pete's GI, and there was a note, but there wasn't any assessment or plan or other imaging. So if the patient wasn't lost to follow-up, they did see them in clinic, but I didn't understand why there wasn't a repeat esophagram. So just something that they need to follow up with. All right, so today our PTCM is going to be the discussion of just foreign. Yeah, go ahead.
So I just want to say, I mean, really kudos to the team that picked it up.
Yes.
If the kid went, another 2 or 3 days, could have had a perfect esophagus. So the kid probably could have died and had a much severe course. Thank God this kid did fine.
Yeah.
If it was missed within a couple of days, definitely could have hurt.
Yeah.
We actually had another one a few weeks ago. It was like kind of similar. It was just like vomiting for a day, and a 2-year-old, but he was like rolling and grunting too, which is always weird in like any patient, especially a kid.
Mm-hmm.
So we got an Xray, and then there was also button battery, and it's like thoracic inlet. And that one was also transferred down to get removed, but then they were too worried about the necrosis around it, so they transferred them to NYU for surgery.
Did you see what that I heard about this case? Did you see what NYU did? Or
no, I wasn't able to follow up, but that button battery was in there for like less than 24 hours.
Yeah.
So that's why it's so important to remove it super quickly.
Yeah, and I'm going to talk about that in a second too. Like, it was kind of awesome that they like were weirded out that this kid was complaining about burning stomach pain, like a 3-year-old specifically, like characterizing that kind of pain, and like wasn't like this is a gastro, which now makes me scared of every gastro I see, but still had that clinical suspicion to further investigate. So yeah, let's talk about button batteries and why they're so kind of important to identify and how to manage them. So in terms of the epidemiology, the incidence is about 10.4 per million people. The fatality rate in 2016 was like less than a %, but that's given like the interventions we have now in modern society. The reason why the incidence has actually kind of increased in the last decade is because now in a lot of toys, they're using these lithium batteries. And the lithium batteries have a higher voltage, like naturally, and actually tend to be a lot larger. So the alkaline batteries, like our AA and other ones, aren't typically as dangerous. I mean, they are something you do have to consider, but it's these lithium batteries, because of their voltage capability, that's the bigger issue. So a general lithium battery will be like 3 voltage, 20 millimeters. And we'll talk about like sizing and how that's also something, a fact that you need to think about. The peak demographic for this is children less than 6 years old, and generally most at a year old. And the common sites of complications are going to be where it can get stuck. And we'll talk about why getting stuck is important, but it's the esophagus is the most common. And actually the nasal cavity is the second most common site. And then the stomach, and then small intestine. Now, why is this like a big deal? Why do we need to care about it? And like, how did that, like how does it cause its injury? So just think about the three ends: narrow, necrotic, and narrow, negative, and necrotic. So the button battery first needs to actually have communication with the mucosa for like an amount of time to cause the injury itself. And how it basically, and that's why kind of being in a narrow area is more significant, because it needs that communication with your mucosa. What happens is the negative pole of that battery, which how the button battery has like a bulging side and a flat side, that flat side is a negative pole. When that negative pole communicates with our mucosa, it actually creates like an electric current by making hydroxide ions. And then those hydroxide ions actually cause basically the like alkalotic necrotic corrosive injury, which causes this necrosis. And we all know alkaline is liquefactive. So that's why it's kind of concerning. This is kind of an interesting video. This just highlights that these injuries can happen like up as early as 2 hours within the ingestion. So this patient was 2 days out of their ingestion. This just shows you how they could, how significant that can be. Yeah, they use Deli Meat. So. So the process happens pretty early, which is kind of honestly impressive that this patient had it there for 2 days and didn't perf. Dramatic cue. Okay, so in terms of your management, first the history. So a lot of times, actually, many of these are unwitnessed. I mean, Tiana just gave that history too. Like a lot of times the kids will be playing around and just put something in their mouth, and then the parent doesn't even see it. So kind of use your symptoms of foreign body ingestion and symptoms of tissue damage to kind of raise your clinical suspicion that there may be a questionable ingestion. So things like coughing, gagging, drooling, grunting, dysphagia are symptoms consistent with like a form of obstruction. And then tissue damage like vomiting, severe abdominal pain, peritoneal abdomen, chest discomfort, fever, hematemesis. The biggest thing that was kind of interesting to me is there was a lot of case reports where there were many missed nasal and ear like cases, because the kid would put it in his ear and then also swallow it, and the parent caught it when the patient swallowed it, so they worked up for the ingestion, but actually where there was cases of missed TM perforations and complications with that. So at minimum, just check the nose and the ear as well. Yeah, go ahead.
I would say that's true for all foreign bodies. I think
yes.
They're distracted by the procedure, like people like eating the nose and things like that. But if a kid is predisposition to putting things in orifices, you should really look everywhere. Yeah,
Emily just said that's going to happen with any foreign body, so always just make sure you check all the orifices in the head and neck, just to make sure you're not missing anything else. And then there's a big difference when a patient says, oh, they just swallowed a coin, like battery buttons and coins look alike. So any coin ingestion is going to be a button battery ingestion until you effectively rule that out with imaging. So in terms of your workup, batteries are radiopaque. You're going to obtain 2 views, and the reason why that's kind of helpful is because on the AP view, you're going to see like the halo sign here, where you just see the shadowing between the double rim, and on your lateral, you're able to see the central bulge of the battery. This is not 100%, so always just still keep the clinical suspicion, but that's kind of how you can tell between a button battery and a coin. As you can see, the coin here is flat with no like lucency, but the button battery itself has a lucency in the bulge. So that's how you can tell. And always just make sure you get an X-ray of the neck, esophagus, and abdomen, which you can get with a chest and an abdomen X-ray. If you think there's a questionable nasal foreign body, you can get a skull X-ray. All right, so in terms of temporizing management, The must-do things, keep them NPO, obviously resuscitate, manage their airway if there's any compromise there, and an urgent consultation. Sometimes this is institutional dependent, if it's GI, ENT, based on where it is, or surgery. I'll probably kind of start with GI. Well, first, I just depend where it is, and then consult what you think makes the most sense, and then they can kind of gear you towards the other direction. There's actually a national battery ingestion hotline as well. It's like partners with the poison control that you can call if you have any questions. And then there is some data about using honey and sucralfate as a temporizing measure while you're waiting for intervention as well. Avoid ipecac, laxatives, and button batteries. And you don't need like to get blood concentrations of like other like metals to make sure they're having like an iron overdose or anything like that. Now, in terms of the honey and sucralfate, I just kind of wanted to focus on that for a second because it's actually in the 2019 Poison Center guidelines as one of the first steps that you do. This is based off a study in 2018 where they actually they put button batteries in little piglets, which is kind of sad. And then they left it there for an hour and they like gave them different solutions to see how that can minimize the level of necrosis and the level of the pH in the esophagus. So they used apple juice, orange juice, Gatorade, Powerade, pure honey, maple syrup, and sucralfate. And basically, they kind of did it in the same method that they're recommending, 10 mLs every 10 minutes. And at the end of that, they noticed that the honey and the sucralfate tended to be the most neutralizing in terms of the pH and the extent of the necrosis. They didn't avoid the necrosis, but was more superficial than the other interventions that they gave. And the placebo or the gold standard was just saline that they compared it with. So that's why this was now introduced into the guidelines. The big caveats here, the kid has to be able to swallow, obviously, and you have to really be sure that it wasn't more than 12 hours out, because after 12 hours is where you have to worry about increased risk of perforation. So for the honey, also, they can't give honey in kids, the younger kids, but it's going to be 10 mLs every 10 minutes for up to 6 doses. And then for the sucralfate, it's 10 mLs every 10 minutes up to 3 doses. It may just be something to talk to GI before you give because they may just want to hold off on it too. But it is as one of the temporizing measures in the guidelines. Okay, so these are the National Capital Poison Center's guidelines and algorithms. It's kind of interesting because even the first step, they kind of have an algorithm where you don't even have to image the patient. I would kind of be wary of this, but I'll kind of talk about that in a second. But the first thing is you think they ingested a battery. Okay, obviously give them the honey if you want, call the National Hotline Center if you want. If they're younger than 12 or they're older than 12 and you know the battery is large, the cutoff they're using is 12 millimeters, then you get the Xray. There's this weird caveat that they put in the guidelines that if the patient's older than 12 and you could surely like say that the battery is less than 12 millimeters and they have no symptoms, you know there's one battery, there was no magnet ingestion, they don't have esophageal like diseases, and they have a reliable family that can watch them, they can actually go home on a regular diet and have a repeat Xray in 10 to 14 days. I would say nobody knows what size battery they ingest. So I personally, in a clinical setting, would probably Xray any kid who comes in with.
Yeah.
Huh?
No lawyer got to that yet.
Yeah. So I just put it there because it's in the guidelines, but I would heavily say you're going to get a lot of unreliable histories, and who the heck knows what size battery they ingested. So just Xray, probably this is the first step. Okay, you Xray them. So you're going to determine, is it in the esophagus or is it in the stomach? And this is kind of important because this is an updated change in the guidelines. But if it's in the esophagus, you're going to go for emergent endoscopy. That's like ASAP. If it's in the stomach, the next question is, did they also ingest a magnet or not? If they co-ingested a magnet, going to emergent endoscopy. If they did it, yeah.
When you say co-ingested a magnet, like do batteries come with magnets on them or?
No, this is like if they just also ate like a magnet. Yeah, I know, right? Kids are like eating whatever. If they have no magnet, but they have symptoms, they're going for endoscopy. So basically anything that's symptomatic or in the esophagus is going for endoscopy. The weird part about these, the updated guidelines is if it's in the stomach, there's no magnet, and they're asymptomatic, you can actually follow this patient up. The time of follow-up just depends on two things. One, the size of the battery, and two, the age of the kid. Younger the kid, higher the battery size, follow up closer. That may be something to also discuss if they're not a reliable outpatient follow-up, you don't think the family could acutely effectively monitor them, that may be somebody you want to admit or obs for serial X-rays. So I would have a discussion with GI about something like that if you're wary that there is a questionable, reliable follow-up. Okay, now the most common complications tends to be the ulceration of the esophagus, then the necrosis, and then perforation, and then strictures and obstruction. The more dangerous ones, like the tracheoesophageal fistulas and bronchopneumonias, are more rare, but they are a complication that you should know about. And then the other big thing is a lot of these complications can happen like weeks after the ingestion and removal. So this is just these statistics are from the Poison Center's paper, but per them, like 98% of patients were diagnosed with perforations by 48 days of post-removal. And even the vascular fistulas were observed up to 27 days post-removal as well. And recurrent laryngeal nerve injuries, I guess if it was higher up, were seen days to weeks out. So it may be something to think about if a kid comes into your ER who is status post a button battery removal and they're having some vague symptoms that may be consistent with a perforation or complications from their necrosis. It's just something to think about. Now, the general kind of algorithm for these inpatient stays, I only put it here because our patient actually exactly followed this, which I thought was very interesting, is to get an esophagram like 1 to 2 days after the endoscopy. So you refer them for endoscopy. If there's even any signs of mucosal injury, that patient has to get admitted. There's no way they get a removal and discharge if there's any signs of mucosal injury. And after that, like depending on how severe it is, you're going to do the esophagram. And then if the esophagram is negative, you escalate them on a clear liquid diet. And then their diet may be advanced to a soft diet as tolerated, and they have to keep that diet basically for a month. And then they have to get just repeat imaging, just follow up because you guys saw there's so many complications of delayed presentation. So you just have to get repeat esophagram and EGD. So that was button batteries. Let's say you get the X-ray and it looks like a coin. Okay. So what's kind of the general workup for that? So this is the most commonly ingested foreign body is coins. The bigger the size, obviously, they're more likely to be impacted. Just as a reference, this is kind of the cutoff they use as increased incidence of like impaction, 23.5. You can see a quarter is 24 millimeters. So basically a quarter is going to most likely get obstructed than a penny or a dime, obviously. But just something to know about the sizes. And it, again, peaks in younger kids. And they have children less than 5 years old have higher rates of impaction. Coins are radiopaque too. You can obtain the tube-view X-ray. Just make sure you can say safely that it's not a button battery and assess them for symptoms of obstruction and tissue damage. Hold on, Monisha asked a question. Do we give them the same diet recommendation for soft food if we are discharging them? If you're discharging them, then not likely. Like the one that was in the stomach with asymptomatic, they can just get discharged home with a regular diet. So this is the algorithm for coin injection. If it's an esophagus in symptom or stomach in symptom, they're going to be getting any symptom, they're going to get an endoscopic removal. So anything in the esophagus and a symptomatic stomach, removal. The only difference is obviously esophagus, the symptom needs to be like ASAP. And then if they don't have symptoms in the esophagus or their stomach and their symptoms, they don't have to do it right away, but they need to do it urgently. And then if they have a coin injection in the stomach without symptoms, you discharge them, normal diet, repeat the X-ray in 2 weeks, or let them know about return precautions about symptoms, and then they come in. So coins seem to be a little bit more safer. Now, magnets. Actually, this is my favorite part of the lecture. There's an MRAP for this month that talks about magnet ingestions, if you guys are interested in just like rehashing it. But this actually has become higher incidence. Here. Urgent, Warshaw had a question, urgent equals obs-em and serial X-ray or discharge them? No, urgent means within 24 hours they need to get the endoscopy. So if GI wants to take them right away, that's fine. Or if they want to admit them and they're going to do it in the morning, that's fine. But they can't go So magnets, the incidence of this has increased within the past decade because of this use of neodymium magnets. Those are like those circular ones that are like really strong. Like everyone puts on their refrigerators. And the reason why is they've been using this in toys a lot more. And kids are just like taking them out of the toy and like putting them in their mouth. And they're being marketed itself as a toy, the magnet. There's like this weird political issue with these right now where they were recalled in 2011 and then they were overturned and not recalled in 2016. And there's actually a trend of incidents from after 2016, between 2011 and 2016 actually went down. So right now, it's still like they're still trying to figure out what federal law they're going to be using in these. But now the biggest consensus is they have to put a warning on the toys that says there's a magnet. These neodymium magnets are like 5 to 10 stronger than the conventional magnets. Obviously, this peaks in younger children, boys more than girls, but there actually is like also a second peak in teenagers who are using like fake piercings, like tongue piercings and nose piercings with magnets that then get ingested. So just be careful with that too. The reason why this is a bit more dangerous is if they take one magnet in, you just have to worry that it's being attracted to the external environment, like button, belt buckles, jewelry, and that could cause some bowel injury. And then more importantly, if you have two that are ingested, they're obviously going to attract across layers of bowel, which you have to worry about pressure necrosis, fistulas, perforations, and obstructions. So a little bit different than the button battery, but pretty bad still. Luckily, magnets are radio opaque too, so you're going to obtain an X-ray. The reason why a tube view is very important here is sometimes the magnets will coalesce and you can't tell if that's one magnet or two magnets. And if you just have the assumption of one magnet, you're going to follow a completely different algorithm. So sometimes on that lateral view, you can kind of discern if that's two magnets together. And then on top of that, it's even harder to say, are these two magnets that are swallowed tracking within the bowel together? Are they two magnets separately that are attracted? And there's not a good way on X-ray to determine that, but there is some suggestion that if you see, like, I guess right here, like a space, then that may actually indicate that there's bowel in between, but that's obviously not 100% thing. So it's also difficult to tell if they're two together in the lumen or across luminal lines. So the algorithm is more so dependent on how many magnets they ingested. So let's say you have confirmed one magnet ingestion. Again, if it's one magnet with another metal object, you're going to use the two magnet algorithm, but you're going to call peds surgery or GI on all of these. The one magnet is basically determined on if they're symptomatic, either in the esophagus, stomach, or beyond. You're going to take them for direct visualization. If it's greater than 12 hours, sometimes they're more concerned that there may be necrotic bowel or perforation. That's why surgery also gets consulted on these. But if they're asymptomatic,